Good afternoon, everyone. My name is Dr. Wiam Hussein from Bahrain. It's a pleasure to introduce the first speaker of the program. He joined us all the way from the United States, from University of Pittsburgh. The title of the talk will be A New Era in the Management of Thyroid Nodule. Our speaker is world-renowned for his work in molecular genetics and pathology. His name is Dr. Yuri Nikiforov, and he will be telling us more about the molecular genetics and thyroid nodules. He is actually the one who established the ThyroSig, him and his wife, at the University of Pittsburgh. By doing that, he was able to eliminate thousands, if not millions, of unnecessary thyroid surgeries, and we would like to hear from him more into the use of this molecular genetics. Dr. Yuri, you're with us now.
Hello, everyone. It is my pleasure to be today with you at this great event, the second annual Congress of Arab Thyroid Association, and to present to you the discussion on the management of thyroid nodules. These are my disclosures. I own some intellectual property related to ThyroSig. I serve as consultant to Sony Healthcare USA, and actually we also have a partnership with Express Med Laboratories to offer ThyroSig testing in the Middle East region. I would like to start saying that the problem, the medical challenge to identify cancer in thyroid nodules is not a new one. About 30 years ago, one of the most famous thyroid endocrinologist in the United States, Ernest Mazaferi, wrote this editorial where he compared finding cancer in thyroid nodules as finding a needle in the haystack. Of course, since then, we have obtained much more sophisticated and high-resolution tools that allow us to do this job better and provide more accurate cancer diagnosis for patients in thyroid, with thyroid nodules. Of course, these tools include high-resolution ultrasound imaging, fine needle aspiration with cytological examination, and more recently, molecular testing. And today I'm going to talk about all these three parts and how they can come together to help us to provide most optimal management for the patients with thyroid nodules. Starting with high-resolution ultrasound, of course, this is now a standard of care. There are different approaches and different classifications of thyroid nodule. Thyroid is just one of that, as of course you know, and I assume that in different countries perhaps there are different approaches. There is an ATA also re-stratification, but most importantly, the ultrasound imaging provide very significant and accurate prediction of cancer risk in a given nodule, in stratifies nodule in most likely benign and more suspicious, and depending on size, recommend performing fine needle aspiration for the nodules that have a substantial probability of cancer in that nodule. FNA with cytological examinations remain a very cost-effective, common, and very accurate way to determine benign or malignant process in a thyroid nodule, of course, in the hands of good cytopathologists. There are also different systems that are used to diagnose specific pathologies in fine needle aspiration samples from thyroid nodules. One of them is Bethesda that we use here in the United States. And indeed, most of the nodules are diagnosed as benign by cytology. And this is a quite reliable diagnosis with less than 3%, and in modern times, there are maybe 1% or less residual risk of cancer in nodules that are diagnosed benign by cytology. Less than 5% of them diagnosed as malignant, and these malignant, cytologically malignant thyroid nodules have very high probability to be cancers on surgery. The problem that remains in the Bethesda classification and in the equivalent classification offered in other countries are categories of so-called indeterminate cytology. In Bethesda, these are Bethesda 3, atypia of undeterminate significance, or follicular lesion of undeterminate significance, Bethesda 4, follicular neoplasm, suspicious for follicular neoplasm, Hürtel cell neoplasm also fall into this category, and to some extent suspicious for malignancy. For this cytological diagnosis, the risk of cancer is significantly higher than in benign nodules, but it's not as high as in malignant cytology nodules. And therefore, the clinical management of patients with such cytological diagnosis is suboptimal. Recommendation before the era of molecular testing recommendation was to repeat FNA or to perform a diagnostic lobectomy or total thyroidectomy. But again, many of this, if not majority of these nodules after surgery will be found to be benign nodules. That's where the third component of diagnostic offering, which is molecular testing, in a way, in fact, have the highest application. Again, just to summarize, cytologically benign nodules, they can be followed, cytologically malignant, undergo surgery, and this indeterminate nodules where diagnostic surgery was typically performed, that's where diagnostic molecular tests offer the highest clinical utility, and they will separate nodules in those highly more likely to be benign and more likely to be malignant. Even more advanced molecular testing can also provide additional information. They can predict if this cancer is a low risk or is a high risk, and therefore can also help to inform the optimal surgical extent for the given node. So this introduction of molecular testing was able to come to the clinical practice because of the revolution in DNA sequencing technology, which we call next generation sequencing. This approach allows us to accurately identify and correctly establish sequencing reads of millions of units of DNA in one reaction, using a small number of cells as a template. Even 200 to 300 cells is sufficient for us using these modern tools to provide extremely deep level of sequencing. Even more so, we can use any kind of materials because the next generation sequencing requires short sequencing reads. We can do sequencing of freshly collected material, we can do sequencing from cytology smears, we can do sequencing of paraffin blocks. This technology, available for over the last 15 years, help us to tremendously expand our understanding of molecular genetics of all cancers, and of course also thyroid cancer, and understand how this knowledge can be translated into clinical practice. Next generation sequencing allow us to understand molecular profiles of virtually all types of thyroid cancer, of benign tumors such as follicular adenoma and Hürtel cell adenoma, that by the way, Hürtel cell now they're called oncocytic adenomas, on precancer lesions such as NIFT-P, on well-differentiated cancer, which include follicular cell-derived papillary carcinoma, follicular carcinoma, and Hürtel cell carcinoma, and C-cell-derived medullary carcinomas, and small proportion of tumors, dedifferentiated tumors, such as a poorly differentiated carcinoma and anaplastic carcinoma, which, however, are important for all of us because these patients have a much higher morbidity and mortality from thyroid cancer. So briefly reviewing the current knowledge on molecular genetics of thyroid cancer. If we are talking about papillary thyroid carcinoma, the most common type of thyroid cancer, most of these tumors develop through mechanism of point mutations, such as those involving BRAF and RAS gene, two most common. About three-quarters of all PTCs have point mutations. About 15% of them have gene fusions. They're also very important. Fusions like RET, NCRK, ALK, and so on and so forth, because actually they can serve as a very important therapeutic target with specific inhibitors for advanced cancers. Then about 7% of PTCs developing through mechanism of copy number alterations. As you can see, this type of alterations rarely overlap in the same tumor. So when we add them together, we know driver genetic mutations in approximately 97% of all papillary thyroid carcinomas. This is a huge wealth of genetic information. So what else we understand and we know about genetics of PTC? So this is a TCGA study published a good number of years ago, but still remains one of the most important studies in our areas. It was performed on about 400 cases of papillary thyroid carcinomas that were studied by all genome-wide available methodologies, whole exome and whole genome, transcriptome, methylome, proteome, and so on and so forth. What this study showed, that although for us, papillary thyroid carcinoma represent as like the same tumor, a single tumor type, this is not the case. Biologically, all PTCs have at least two main subtypes, which are called BRAF-like and RAS-like, which is very important to understand and keep in mind clinically. Why? So let's look at this diagram. This is the messenger RNA profiling and microRNA and DNA methylation and transcriptome. As you can see on the left, there is a lot of blue, which means that this is a lower level of this expression of these markers, and on the right, there is a lot of red, which is a high level of expression of these markers. So what else we can see? We can see that the BRAF-like tumors, they are, in terms of their phenotype, they have very low proportion of follicular fraction. They are mostly classic papillary carcinomas and tall cell variants of papillary carcinoma. RAS-like tumors, they are mostly follicular variants of papillary carcinoma. There is also difference in encapsulation. RAS-like tumors mostly encapsulated, and BRAF-like tumors are infiltrative. Again, classic papillary carcinoma versus follicular variant of PTC. But more important clinically, when we looked in the study at thyroid differentiation score at expression of markers associated with thyroid differentiation, in BRAF-like tumors, most of them were suppressed, and in RAS-like tumors, most of them were preserved. So in addition to BRAF, a RAS mutation, virtually all other mutations can fall into either BRAF-like or RAS-like subtype of papillary thyroid carcinoma. Again, to summarize some of the most important finding in this study, when we look for expression of thyroglobulin, TPO, sodium iodine synthetase, dioxidizers, and so on and so forth. So all genes that are involved in thyroid metabolism, iodine absorption and processing and organification, So all of these genes are suppressed, are downregulated in BRAF-like tumors, and they preserve at the level close to the normal thyroid tissue in RAS-like tumors. So why is it, this is important? Because we learned that BRAF-like tumors will lose ability to trap radioactive iodine at relatively early stages, while RAS-like tumors will preserve it for a long time. What about follicular thyroid carcinoma, the second most common type of thyroid cancer? These tumors have molecular profiles very different from classic papillary carcinoma, but this profiles close to the follicular variant of PTC and to follicular adenomas, because this is the same biologically very similar group of tumors. So follicular thyroid carcinoma, they are also RAS-like tumors. So if we take papillary thyroid carcinomas and follicular thyroid carcinomas, put them together and split them into two groups based on their biology, we will be talking about BRAF-like tumors and RAS-like tumors. BRAF-like tumors have infiltrative, very irregular borders that can be even seen on ultrasound, whereas RAS-like tumors are encapsulated, and even when they invade with a smooth border, and this smooth border is clearly seen on ultrasound. So in addition to difference in the appearance, I mean, BRAF-like tumors, as we said, are classic papillary carcinomas, so tall cell variant, and RAS-like tumors are follicular variant of PTC, FTC, NIFP, and follicular adenomas. Again, to summarize, it's very important to remember that BRAF-like tumors, they spread to lymph nodes first and only later to distant sites. And they're prone to lose markers of thyroid differentiation at very early stage. Whereas RAS-like tumors will spread to distant sites and virtually never to lymph nodes. You almost don't even need to map the regional lymph nodes in the neck if you are dealing with RAS-like tumor. But if they metastasize to distant sites, to bones, to lungs, but they will retain markers of thyroid differentiation for a long time, and therefore can be successfully treated with radioactive iodine. What about Hürtel cell tumors, the third most common type of well-differentiated cancer? These tumors have mitochondrial DNA mutation, they have some nuclear DNA mutation, but most importantly, they have a very peculiar, very unusual type of molecular alterations, which is called neohaplodization of genome. They lose one of two copies of many chromosomes, and some of them have two copies of chromosome, but this is the one chromosome that is duplicated, and second allele is still left, still lost. Again, this is called neohaplodization of genome. This is a highly characteristic molecular alteration of Hürtel cell carcinomas and some adenomas, which we believe serve as a precursor for carcinoma that can be detected using molecular tools. Finally, when we are talking about dedifferentiated thyroid cancer, those cancers have mutations and gene fusions that are common in well-differentiated cancer, but also they have secondary late events, late hits, such as TERT mutation, very important for aggressive thyroid cancer, and P53 mutation, which is very important for complete dedifferentiation and transformation to anaplastic thyroid carcinoma. So to summarize, when we are talking about molecular classification of follicular cell-derived thyroid cancer, it develops through three different pathways: BRAF-like, classic papillary carcinoma, RAS-like, follicular pattern encapsulated lesions, and copy number alterations driven pathway, which is a Hürtel cell carcinomas. All of them can acquire additional molecular alterations, dedifferentiate and transform to fully differentiated and anaplastic thyroid carcinoma. So how molecular tests can help us, even in preoperative setting, to predict if this is benign or malignant, and if it's malignant, how aggressive this cancer can be. We have already gone through several generations of molecular tests. Some of them were first generation, these were small panels that have relatively low sensitivity and specificity. We went through the second generation, and now there is a third generation of molecular tests, which really are at this time the most advanced type of molecular testing that we can offer to our patients. Example is a PharmaGSC and Thyroid version 3. I'm going to talk mostly about Thyroid version 3 because this is a test that we use here at the University of Pittsburgh, and we have the largest experience with this test. So modern molecular tests can detect what type of cells are within the samples that you collected for analysis. If these are thyroid follicular cells, or these are parathyroid cells, or this is a medullary carcinoma cells, or even metastatic lesion, and then perform classification analysis to detect molecular profiles, to predict cancer risk, and predict cancer probability. I would rather start with cancer probability by genomic classifier, and then cancer risk for recurrence if the case is positive for molecular testing. So we are going to discuss two clinical scenarios. When the patient has a suspicious nodule, nodule is FNA. FNA comes as indeterminate cytology, but indeterminate cytology yields negative molecular test results. What we should expect in these nodules? This is a multi-center study performed by the international study. It involved 10 centers, 9 in the United States and 1 in international in Singapore, approximately 250 patients with Bethesda 3 and 4 nodules. The test shows sensitivity of 94% and negative predictive value of 97%, which means that the residual cancer probability in this nodule is as low as 3%. So this is the findings in the main study, was replicated in multiple other independent studies, again showing high sensitivity for detecting cancer and negative predictive value ranging from 97 to 99%. Again, given reassurance that if no molecular alterations are found, this nodule is very likely to be benign. So how many patients with indeterminate nodules we can identify negative molecular profile and therefore predict that these are benign nodules that probably can be managed without surgery? This is a very large study of about 50,000 thyroid FNA samples from different institutions, close to 1,000 institutions in the United States, showing that in Bethesda 3 and Bethesda 4 nodules, 68% of nodules were called negative for molecular testing. Again, benign call rate close to 60, 67, 68%. So quite similar results were showed also in certain different studies by Afirma. So again, the third generation modern molecular tests can identify as likely benign close to 67, 68% of nodules with indeterminate cytology. So what happened in this nodule for patients with these nodules in the institutions in the United States? This is one of the studies, one of many studies currently published from UCLA, showing the outcomes for this patient and showing that non-operative management was pursued for 87% of nodules with indeterminate thyroid cytology and negative molecular testing, which gives us the reassurance that if molecular testing is negative, the vast majority of these nodules may avoid diagnostic surgery with its complications, risks, and expenses. So what if thyroid nodule with indeterminate cytology comes with positive molecular test results. One of the big advance for tests such Thyroid that studies molecular profiles for virtually all genes that are involved in thyroid carcinogenesis, that it's not only predict that this is a likely cancer or NIFT case, but it's also provide more specific prediction of what is the phenotype, what is the cancer type that you expect to see on surgery, and even what is the risk for cancer recurrence. This is again a multi-center study, approximately 250 patients, and positive test results came in different flavors. 2% of those patients of positive test results was positive test results for high-risk alterations. That is a very high probability of high-risk cancer, and we talk about it in just next few minutes. Then there is a significant BRAF-like group. You remember we discussed these are almost all of them are cancers, classic papillary carcinomas or told cell variant of papillary carcinoma. We will also discuss the risk for recurrence of this group. Then there is a RAS-like group, very large group, approximately 57% of all indeterminate thyroid nodules. These are follicular encapsulated tumors. About 60% of them are cancers, about 38% of them are benign follicular adenomas. But these are tumors, these are not hyperplastic nodules. These are clonal neoplasms that theoretically can progress to cancer. Then there is molecular test results positive for copy number alterations. We already discussed that most of them are Hürther cell carcinomas or precursors for Hürther cell carcinomas. And there is a smaller proportion of follicular variant of papillary carcinoma. And then there is a group of gene expression alterations. This is a group where we can detect medullary thyroid carcinomas. We can detect parathyroid glands that mimic on cytology indeterminate thyroid cytology. We can detect metastatic thyroid lesions, and so on and so forth. So this is a level of granularity that can be provided for positive test result. So finally, I want to talk a little bit for a few minutes for genetic markers of cancer risk stratification. Over the last 10 to 15 years, a lot of work has been done, and our understanding of the use of molecular markers for predicting cancer risk for recurrence has also expanded dramatically. This is just several studies. This is one very nice observation from South Korea on 551 patients with differentiated thyroid cancer. And when we look for disease-free survival, so as you can see, tumors that are driven by RAS mutations only have extremely low risk for recurrence, close pretty much to 99%. Tumors with BRAF V600E mutations that have about 5 to 10%, 15 to 20 years probability of recurrence. So this is the American Thyroid Association ATA intermediate risk group. And tumors that have combination of RAS plus TER and BRAF plus TER are high-risk tumors with close to 60% recurrence expected within the 15 years of diagnosis. What is really important is that this is not only recurrence, even survival. When we are talking about the cancer-related survival, it can be stratified based on molecular testing. Again, this is a BRAF alone, this is a TERT mutations alone, and this is BRAF plus TERT mutations. As you can see, survival significantly decreased. This is a study from Johns Hopkins. I think this was international, led by Dr. Minzhao from Johns Hopkins, but also involved multiple international centers. So really, this becomes a new frontiers for molecular testing. How can we use genetic profiling in order to predict how aggressive the cancer can be, and therefore help to inform us, the extent of surgery, need for radioactive iodine, the intensity of the follow-up after surgery. If all management categories can be significantly improved if we can know how aggressive this cancer can be. This is a study from our institution led by one of our surgeons, Dr. Lynn Van Heep, where she looked at about 60 patients with differentiated thyroid cancer with distant metastasis developing within the 5 years of post-surgery. And she compared it using the propensity scoring with the same number of patients who didn't develop distant metastasis during this period of time. And then all molecular profiles based on the literature and the studies in our laboratories were assigned to low risk, intermediate risk, and high risk. As you can see, RAS-like tumors and RAS-like alterations, they are low risk, BRAF V600E and BRAF-like mutations, they are intermediate risk, and combination of early hits with late hits such as TP53 and so on and so forth, third mutations alone at high allele frequency and so on and so forth, these are high risk alterations. So these real alterations in this case control study provided a very high level, high prediction rate of low, intermediate, and high risk cancer. However, this study was performed on surgically removed tumors. And more recently, just this year, papers by Jason Liu and colleagues that came out on surgery provided first validation of using the molecular risk groups for predicting of cancers in preoperative setting. It was a large study, 578 patients with differentiated thyroid carcinoma. Even on relatively short follow-up, the molecular risk groups were able to predict low, intermediate, and high risk for recurrence. So to summarize, how can we add molecular testing to other diagnostic modalities that we know already and have extensive experience with, which is the ultrasound imaging and FNA cytology, to further improve our management of patients with thyroid nodules? If we have the Bethesda 3 to 4 cytologies, the patients who fall into this category of indeterminate cytologies, and we perform molecular testing, first of all, we can detect about 1% of nodules that are either medullary carcinomas or parathyroid glands or non-thyroid follicular cell lesions, frequently metastatic in these tumors. But of course, most of them, vast majority, about 99% of them, are thyroid follicular cells driven nodules. Those will be classified by molecular testing into different categories. As negative for alterations, these nodules have extremely low probability of cancer, probability about 3 to 4%, and these patients can be safely observed. They can be currently negative. These are likely a precursor tumors for cancers, benign adenomas, Hurter cell adenomas. These patients need to have active surveillance, and they can be positive, but positive in a very granular way for RAS-like alterations, for copy number, Hurter cell type alterations, for BRAF-like alterations, and for high-risk alterations, with surgical management that can be really tailored based on the individual molecular profiles. I would like to finish with this study from UPenn, from Dr. Susan Mandel and colleagues, who look at 415 thyroid nodules with Bethesda-3 and 4 cytology and molecular testing offer 71% benign colorate. Again, about two-thirds of patients with these nodules will get negative test results. They also acknowledge 45 independent molecular profiles. And in their study, 89% of patients avoided surgery. So they concluded that our results affirm that a more comprehensive mutational fusion panels reveal complex molecular profiles of patients with Bethesda-3 and 4 nodules. High benign call rate and high NPV allows the majority of patients to safely avoid surgery, while also providing information to guide individualized patient management. So before our surgeons go to the operating room to perform surgery on molecular testing, they now have a much broader repertoire of diagnostic tools, which include ultrasound imaging, FNA cytology, and now molecular testing, which together can inform the most appropriate management for patients with thyroid nodules. With this, I thank you for your attention, and if you have any questions, I will be happy to answer them. Thank you.
Thank you so much, Dr. Yuri. That was a fascinating talk about the future of thyroid nodule management in the era of precision medicine. It was a fantastic talk. We don't have any time for questions and answers.